So welcome everyone. You can see the slide, I believe. Our theme today is the appendix. My purpose in doing that, of course, is to make the familiar become more interesting, as well as just to remind ourselves that, we look at appendices and gallbladders in surgical pathology all the time. And sometimes we can become a little bit, how would I say this, a little bit maybe disrespectful of the patient, and don't always give these routine cases all the attention that they deserve. And so I'm hoping that as we see some variations in the appendix, that you'll enjoy both the pathology as well as the reminder that each specimen represents a patient, and even though it's a routine kind of specimen, it may hide a very interesting, or at least unusual finding that the patient deserves to know about. So our first case was a 10-year-old boy who had some right lower quadrant pain, very typical finding and so forth. As we look at the sections, and of course routinely we section the distal tip and some of the proximal sections. So one of these cross sections may be the proximal margin. We don't see much in the way of inflammation here. We see that the mucosa has a fairly normal architecture of colonic glands, or colonic type glands, lymphoid follicles, some submucosa with maybe a little bit of fibrosis here. You see a little bit more fibrous tissue than sometimes you see, but probably that's within the realm of normal. And not much in the way of inflammation here in the wall. And so we wonder if the patient really had appendicitis. Would we just sign this out as normal, go on to the next case? You want to look in the distal tip for things like neoplasms and so forth. But I think it's also very worthwhile to remember to look at what's inside the lumen, see, you can get an idea of what maybe the patient was eating or other sorts of things. You might also get maybe a few clues, things like this that look a little bit granular or something, or maybe little cystic structure-like things. If you were really savvy and picked up on this, you also would have noted that we have down here at the very distal tip another structure that looks a little bit unusual here. And of course, if you know me, one of my favorite things is parasites in tissue sections. And this is absolutely a wonderful cross-section of this parasite, which is virtually diagnostic by virtue of these two structures on each side, these so-called lateral wings or alae. Really nicely define the pinworm. And of course, along with that, you can see internally the eggs in this very gravid uterus in various stages of development. Of course, pinworms have a digestive tract as well. And so you can see that there. So this is Trichuria trichiureus infestation. It's hard to see that there's much reaction here in the appendix. And so I'm not sure we have an explanation for his pain per se, but having done that, or having removed the appendix and made that diagnosis, enabled them to treat him with mebendazole or whichever anti-helminthic drug is in use at the time, should allow the patient to at least recover from that and go on to normal growth and development. Of course, pinworm infestation is not a life-threatening infection by any means, but it can cause symptoms, can cause diarrhea, maybe even a little bit of weight loss. Certainly, perianal pruritus is also a kind of common symptom with that. But when you see it in tissue section, this is almost always the area where you will see it is in the appendix. And so remembering to look for the worm either in cross section or in other longitudinal sections, and to look for the eggs potentially in the fecal sample. Did any of you see the eggs in the feces? They weren't really evident here to me, so if you did, I was hoping that you might highlight those. Okay, well, let's go on to case number 2. And we'll see if it pops up here the way I'm hoping it does. Here we go. Opening, opening, opening. The history here was a 35-year-old woman undergoing surgery for an ovarian mass. So again, the appendix looks fairly unremarkable. But I think as you picked up from the blue ink here, the surgeon saw something a little bit odd here in the tip of the appendix. And so we're going to focus right down on this tissue. So as you look at this, any of you have any thoughts about this? Dr. Leah Shreveport, if you saw this, what would you think if this was one of your specimens that you were managing? You haven't unmuted yourself, so I'm not sure, maybe you're not able to answer. So essentially, you've got some structures with a central lumen filled with some pink secretions. You have variable sizes to the lumina and so forth. We see, as we look at the nuclei here, kind of rounded structures and so forth. So one question is, could these be mesonephric remnants? I think that's an interesting thought, and so forth. I think the appendix I would be a very unusual site for mesonephric vestigial remnants. Usually that's not the tract where the mesonephric remnants would occur, but they could have been displaced embryologically. The other thought here is that, if you just took a high magnification view of this, particularly this area over here, and I told you we were in the neck, you'd probably say, oh, this is just, ectopic thyroid tissue or extrathyroidal thyroid tissue. You've got the scalloping of some of the pink secretion, the colloid-like stuff here. You've got the rounded, variable-sized follicles and very uniform nuclei. So I think that, in fact, was the diagnosis, is that this is thyroid follicular parenchyma. And then the question becomes, how in the world did we get thyroid parenchyma here at the distal tip of the appendix? I think that's the very interesting question, is that sort of defies our understanding of biology and so forth. It's certainly not provoking much in the way of response. So I think you have to consider a couple of possibilities. Is this just an ectopic neurocrest-derived tissue? Is this a metastasis or an implant from either a primary thyroid follicular carcinoma, very unusual location for that to occur. But the clue was here, I think, that she had an ovarian mass. So we know that there are times when people have ovarian lesions in the teratoma range, can have peritoneal implants of things like glial tissue and other types of tissue. And so I think what this represents is that this patient actually has a teratoma, maybe with a component of struma ovariae, and that there are associated peritoneal implants related to that lesion. This was not my case, and so I don't have a solid knowledge that that's what was the finding in the ovary, but that's my presumption that this is most likely related to an ovarian teratoma type of lesion. But certainly an unusual finding, and again, something that is a challenge to our understanding of how disease occurs and is spread. So the immunoperoxidase stain, which was designed to help you clarify this, is the TTF1 stain. And as you can see, these little islands light up nicely with the TTF1 nuclear staining in all of this tissue. So that sort of corresponds and supports the diagnosis. So let's see, we have a couple of questions in the chat or comments. Very good. Metastatic neuroendocrine tumor, mets from the struma ovariae. The surface epithelium had serrated areas. I don't think so. I think that that's more the type of changes that you get fairly typically with thyroid epithelium. So very good questions and challenging thought processes with this case. All right, well, let's go on to case number 3 and pull that up. The history here is a 40-year-old woman who has recurrent pelvic pain. And let me let in Sahar from Egypt. So this is another sort of unusual specimen. Here we have obviously appendiceal tissue here, and then we have this bulge out here of sort of pinkish blue stroma, and then up here we have another lumen, and the wall here shows some glandular inclusions. And so if you had just this here, I think most of you would make the diagnosis probably of endometriosis. You have a little bit of stroma here. Some might say endosalpingiosis, but usually if it's in the muscle, has a little bit of stroma, that's good for endometriosis. So what's going on with the rest of this sample is that it looks as though we have similar type of glandular tissue with varying amounts of stroma, some a little bit more over here, much less over here. And surrounding this, we have this very florid smooth muscle proliferation as well. And this is forming a mass-like lesion with cystic changes. And the muscle here is not organized like it's a tubular structure. It's just more organized like a tumor type of lesion with varying amounts of gland to stromal tissue. Here's more pure stromal type muscular tissue. And then next door we have these nodular clusters with central glands and stroma, more clear-cut endometrioid type differentiation with associated smooth muscle. So does anybody have a name that you want to apply to this process that sort of describes what's going on here? We know that endometriosis in the appendix and elsewhere is fairly common. But what about this sort of a situation where you've got glands and this very abundant, prolific proliferation of smooth muscle along with it? Anybody want to offer a name? So you could be very descriptive with this in terms of reporting. But there actually is a name in the literature, which is, well, let's see, someone's got it typing in a name here. Adenomyoma, very good, Jennifer. I think that would be a very good name for this. It certainly describes the process. And if we had this just in the uterus, that would be what we would say is adenomyoma. But where we're involving peritoneal surfaces, the people have used the term leiomyomatosis peritonealis disseminata. That doesn't include the glandular component particularly well. So I suppose you could use the term adenomyomatosis disseminata peritonealis or something like that. If you were a Latin scholar, you could come up with the right endings and suffixes for that sort of thing. But essentially, this is adenomyosis that has disseminated to the peritoneum. It's the combination of the glands and the myomatous stroma that is interesting. Now we know that there is leiomyomatosis disseminata. There is a benign metastasizing leiomyoma. Oh, this is essentially the adenomyoma version of that process. And in some situations, this can be pronounced. Certainly can be symptomatic, as in this patient with peritoneal pain or recurring pain and those sorts of things. Yeah, so nodular smooth muscle metaplasia, you could also use that term would be fine. A very descriptive kind of thing. I think the important thing is to communicate that this is not a malignancy. It is a neoplasm, a new growth and so forth, and it has some spread capability, but in general, aside from the potential maybe for causing adhesions or obstruction, it shouldn't be, and symptoms, it shouldn't be considered a neoplastic process. All right, well, very good. I think this was a singular case in my experience to see this sort of process here. So let's go on to case 4. A 30-year-old man who has recently immigrated. And here again, we see the appendix, traditional 3 sections, proximal margin, mid portion, and distal tip. And not much in way of dilatation of the lumen. But as we come into higher magnification, we can see that there are some things going on here in the submucosa areas. You can see these sort of jump out at low magnification. And then we have some things in the lumen here as well. So let's look at what's in the lumen, see if this gives us any clues. No, it just looks like calcified debris, so that's not going to give us a clue or answer here. And we look at some of these. These are clustered, they're fairly uniform in size, but they also look calcified. But notice that we have a little bit of a rim around this, as you can see. A little bit of internal scalloping and variability. So kind of hard to pick out for sure, but I suspect, Sahar, you know exactly what this is. Well, Venkat, you know as well, schistosomiasis. Very good. Schistosoma mansoni is the more frequently encountered one. Usually in the urologic system is where we encounter that most of the time. But the other varieties can occasionally migrate up vessels into the splanchnic and mesenteric circulation and deposit their eggs there. And this, of course, illustrates the way that the eggs then get access back to the outside world, is that they deposit them in submucosal vessels, and hopefully then they ulcerate into the lumen and escape into the environment in that way. Not as efficiently as in the bladder with Schistosoma mansoni. But you can see there's quite a burden of them here in terms of eggs and so forth. Now, as you might imagine, this provokes a little bit of response in terms of fibrosis, but it's actually fairly remarkable that there's not a greater degree of inflammatory response to this. And so you might ask the question, why doesn't the body respond to these more aggressively? What is what's going on? What is the organism? What is in the structure of the shell that seemingly makes it less antigenic or doesn't provoke any sort of real giant cell reaction? All that we get is a little bit of fibrosis. I think this is a fascinating area of response. So are the parasites dead and then that's the reason why there's no response? Well, I don't think so. Because we know that, foreign material in plants and other sorts of things will provoke a giant cell response at the very least. And so this is, I think, an interesting area of investigation in terms of possible things. Yes, Sahar says they're old. Yeah, they are old. These have been there a long time. And that's why they've calcified. But I think even at the very fact that they're still here calcified, and you can identify the shell, this outer membrane of the organism, without much in the way of response, is a very intriguing question. And we do a lot of things to suppress the immune response in other settings, with transplant pathology, with transplant of organs and so forth, bone marrow, liver, kidneys, other sorts of things. And that's a big problem for us, is suppressing that immune response. What is it that we could learn from these parasites, which they seem to do quite well in reducing the inflammatory or immune response? I think very interesting research question. I hope maybe some of you might think about that or take up that opportunity to investigate that. Is there this and other parasites very similarly oftentimes inhabit the body for lengthy periods of time without evident response? Okay, maybe eosinophils and so forth. So we'll move on to a different scenario here. This is a 50-year-old man who has a right-sided colon cancer. And so they've resected the colon and you section the appendix. And here we see that the distal portion is all fibrosed down. Very little of anything left here, very common finding. But even in that situation, we can oftentimes find pathology in the appendix. And so what do we see here? Well, one thing that you should immediately pick up on is the diminished amount of inflammation of the lymphoid population. We have a few lymphoid aggregates over here, but broad spaces with little or no lymphoid inflammation. And then as you look at the epithelium here, you see the very characteristic serrated pattern of the epithelium, tufting upwards, even a little bit of villus formation in some areas. This also shows the sort of deep glandular dilatation and lateral growth of these lesions. This is very recognizable as a serrated adenoma. So that's not a big challenge, but sometimes, it does, it may not be this florid, and you may just have a little hint of it in some areas like this, where you're seeing maybe slightly altered columnar epithelium, a little bit of basilar dilatation and branching here. It's okay in that situation to say, you've got a few features that suggest the possibility of a serrated adenoma or a adenomatous neoplasia in the appendix. This is particularly important because the serrated lesions on the right side of the colon can progress to colon cancer, of course. And if you find this in the appendix, in an appendectomy specimen, then that certainly is going to create the situation where they're going to want to continue to screen the patient's colon for other polyps at an increased frequency. Sessile serrated adenoma of the appendix. This is not yet an invasive neoplasm. We don't have the low-grade mucinous neoplasm changes here. It's still fairly normal submucosa aside from the absence of the inflammatory component. Okay, question here. Yeah, very good, Venkat, very good. Boat-shaped crypts. I like that description. Boats or boots, some people like to use the cowboy boot analogy rather than boats, but either way, you get this abnormal shape to the deep crypts. Okay, let's go on to the next case. 36-year-old woman with right lower quadrant pain, and so here we see a somewhat different story. Here we've got an extraluminal mass out here, and we don't see too much here in the lumen. So we'll look first in the lumen at what's going on inside the appendix. Again, lost some of the lymphoid inflammation, and our epithelium is kind of blunted or changed and doesn't look particularly mucinous here. We've got a little bit of sort of granulomatous response, a little bit of luminal erosion, and so forth. So this is an altered lumen and mucosa, but it's not clearly neoplastic in this section. And so if this is your section and you've got this mucinous process here that is within the wall and outside the wall, then the question becomes, where did this come from? And how did it get here? Now, as we look at this mucinous material, we see that it's got intervening areas of, dense fibrosis, inflammatory cells. And we want to look very carefully at the mucin to see, is there any evidence of an epithelial component? Sometimes you may actually want to do a cytokeratin stain, CK7 or pan-CK, to see if you can identify true epithelial cells. The warning being, of course, that sometimes macrophages can take up keratin filaments and therefore stain positively. So you have to be very careful and that you're not over-interpreting cells as epithelial cells when they're really just macrophages that have ingested keratin proteins from another cell of origin. So we're not seeing mucin here, or excuse me, we're not seeing epithelium here in this, either the large space, which is very inflammatory, or in those smaller infiltrative spaces. And so the question here would be, is this peritoneal mucinosis from another source? And that's possible. But in the setting where your epithelium is abnormal in the appendix, I think we would be obligated to first rule that out in the appendix. And so doing complete sections, thoroughly looking to make sure you don't have some degree of epithelial proliferation or mucinous metaplastic type lesion in the appendix is appropriate. Now, as you know from looking at the staging on these lesions, if we have epithelium here in the abnormal epithelium in here and mucin out here, that's considered to be a low-grade appendiceal mucinous neoplasm with spread, transmural spread. We don't necessarily have to see a contiguity between the lumen and the extramural mucin in order to make that case. We don't know how that happens, but it happens often enough that the staging criteria have taken this into account. So this could be a low-grade appendiceal mucinous neoplasm, but certainly it is appendiceal adenomycinosis or appendiceal, pseudomyxoma kind of mucinosis, acellular mucin. And this is the important thing here is that the clinicians understand that there are not malignant epithelial cells here to be treated. This is not something that's going to respond to chemotherapy or something like that. Now, the question is, could we qualify any of this epithelium as dysplasia? I had a hard time with that. I do not think that I could truly say for sure that this is dysplastic. This gland here is a little bit more hyperchromatic. And so you might wonder about this as being dysplastic. But I would really want to see more clear-cut evidence of dysplasia and would section this much more thoroughly to make that definition. So that's a little discussion about peritoneal involvement with mucin, which is acellular and does not have evident epithelial neoplastic cells out here in the peritoneal mucinosis. Okay, we'll take a little different variation on this and look at case number 7. They're going to have to go more quickly to get through here. So here is another example, but here in this situation, we have the lesion more fully developed. So we see outside here blue mucin, some calcifications and so forth. But then looking inside the lumen, we can see here the nice clear-cut mucinous epithelium, basal nuclei, but some degree of dysplasia. And so this is a neoplasm. Now, the qualification or classification of this neoplasm is that of low-grade appendiceal mucinous neoplasm. And one of the clues to making that diagnosis is this very hyaline-appearing dense collagen base that you see these cells resting on. When you see this kind of a epithelium resting on this kind of a hyaline fibrotic base, either in a primary or a metastatic site, you should think of low-grade appendiceal mucinous neoplasm. So that's true whether you see this in the ovary or whether it's in the appendix. So question. Yeah, question about our potential contaminant of phages picking up keratin proteins. And yes, a CD68 or 168 would help to identify the staining simultaneously with both those markers, and that could be, alleviate that issue. So here again, the situation is we have the epithelium here within the lumen or within the area, but the epithelial or the mucin out here is still predominantly acellular and just macrophages again. So you would follow the staging criteria and conventions to stage this, but noting that the mucin that's outside the wall is acellular, again, is very helpful to the clinician to understand the kinds of therapies that are likely to be helpful as opposed to those that are likely to be just toxic and not particularly helpful. So the low-grade appendiceal mucinous neoplasms, very low or no epithelial cells in the mucin, even though it's present within the lumen of these cases. Okay, and contrasting case with this. Case 8 is a 60-year-old woman who had an omental cake and a pelvic mass. Oops, let's see, looks like we didn't go. Pick up the slide link. We'll pick it up here now. So anytime you see an omental cake, of course, in a woman, you're going to think first of ovarian carcinoma, most likely serous carcinoma. And that's just kind of the norm here. And usually when you've got serous carcinoma, this is a disease that is spread by the coelomic spaces. It's not spread through lymphatics or blood vessels in the usual sense. So it arises probably in the distal fallopian tube, and it has this very characteristic morphology, high-grade nuclei, sort of amphiphilic cytoplasm, variable cystic and papillary structures, very aggressive looking tumor. And usually it spreads, as we said, along peritoneal surfaces. Now, what makes this lesion unusual is that this lesion has acquired the capability to invade. And here we see it actually invading the appendix and involving up to the submucosa and mucosal surfaces. So this makes this lesion essentially a stage 4 lesion when it involves the mucosa and has penetrated the wall. That is no longer just transcoelomic spread. That is tissue invasive capability and indicative of a higher stage and more aggressive, more higher level of risk and so forth for this patient. So sectioning so that you can evaluate that spread is very important, and reporting it accurately also will be helpful. Okay, so serous carcinoma is something we see, almost daily, certainly every week in our practice, and so you get very used to it. But if you have quite a case like this, the kind of immunostains that we would use, typically we use WT1 to define the tissue as serous, Pax8, WT1, those are nice indicatives of serous carcinoma. And then P53 that is mutated, either showing overexpression or loss of expression. Those findings together make for a pretty strong case for serous carcinoma arising from the gynecologic tract. And you can pretty well rule out most of the other entities with those findings. All right. So the next case is a 55-year-old man with right lower quadrant pain. And so I show this case with the intention to remember that older adults get appendiceal disease, and they can rupture and die if not attended to promptly. In fact, a very tragic story in my brother's family was that his father-in-law, who was a hardworking farmer, had some pain that was bothering him, but it was harvest season. He needed to get his crops in, and he said, "Oh, I'll just work through it and then take care of this, when I'm done harvesting." But unfortunately, by the time he got to that stage, the rupture had occurred. His peritoneum was widely infected, and he was toxic and passed away from a ruptured appendix. Well, so this is another case where it looks like we have, maybe a thickened wall here. The appendix, this is the orifice of the appendix, and everything here is thickened. And we see what's causing the thickening here is a neoplastic proliferation. And as you look at this process, you see lots of clear cytoplasm with peripheral nuclei, the sort of classic signet ring cell morphology. And so what's our differential with this sort of a morphology? Well, primary tumors, of course, we would think about that. Very good. Goblet cell adenocarcinoma. And that is a lesion. This is a lesion in this location that's relatively more frequent here than in other locations. And this is actually the reason why we're beginning to have a more understanding about these tumors, which have a combined neuroendocrine and non-neuroendocrine neoplasia. So many of these lesions like this will be a combination of neuroendocrine cells showing staining with markers like synaptophysin or chromogranin, as well as more conventional adenocarcinoma with the mucin droplets. In this case, I think this is a poorly differentiated signet ring cell adenocarcinoma, but you would want to do the neuroendocrine markers because goblet cell adenocarcinoma or goblet cell carcinoid lesions can occur in this location and have a somewhat better prognosis than the combined or the pure adenocarcinomas. Another comment and question. Yes, African carcinomas. So these tumors that have divergent differentiation showing neuroendocrine and non-neuroendocrine features. And sometimes those will be located within the same cell, which will have both components, or sometimes it will be in a more kind of parallel or different areas of the same tumor will show that differentiation. And the appendix is one of these areas where being careful to define that lesion and identify it and give proportions of neuroendocrine versus non-neuroendocrine tumor can help to guide prognosis and therapy. The immunostain that was provided with this was a pancytokeratin stain, which showed all of these cells to be nice and strongly positive. Now, this is a florid case. Sometimes your lesions will be much less pronounced. As is often the case, the goblet cell carcinoid tumors will present in the submucosa or in the wall. And they will not, as this case does, have much of a mucosal component. So here you can see that this has surface involvement it's grown up into the mucosa and submucosa here, and therefore this may be a primary tumor that arose in the mucosa and grew downward as a primary mucosa-based carcinoma. So the question is, how would I differentiate goblet cell adenocarcinoma versus signet ring cell adenocarcinoma by morphology? That's a very challenging question, and I don't think we would be very adept at that. I think the goblet cell adenocarcinomas usually have more defined areas of sort of structural mucin production in those lesions, and a little bit more of the goblet or of the carcinoid component where you may not have goblet cells, you may have small nests of tumor. But I think you really can't reliably do it without good evidence of immunohistochemistry. So I'm sorry that that's the case. Now, another question that comes up with these lesions is, are these mismatch repair deficient and so forth? And we routinely are doing our mismatch repair lesion proteins and assessments on these kinds of tumors where they have this kind of differentiation. As far as we know, however, these tumors in the appendix don't have the same proportion of cases that are positive, say, with HER2, and therefore amenable to treatment with those small molecules. Well, let me rush through these last two cases if we can, or at least the next one, to sort of round out the morning. Here. Well, it's not letting me open. Was that the so these are the DAPA cases. So let me see if I can pull these up in DAPA. Well, that's not the case I want. So we're just about to the end here, and I apologize for those of you who just joined that you missed our discussion, but I will be posting the video later today. And these last two cases are from the DAPA site. Let's see if I can pull it up now with this open. So let's see. So this was a case that I pulled from our slide library. Let me show you case 11, because that was from my own personal collection here. And this is a patient who had appendiceal Crohn's disease. And they'd had several surgeries for Crohn's disease, and then they gave us the appendix and a portion of the rectum and other cutaneous lesions, which they biopsied. And so this was a lesion from the groin area, quite a distance away from the anal tube. And as you can see here, we've got an ulcer, we've got some granulation tissue, we've got dense inflammation here, but we also have here areas of kind of histiocytic response, some multinucleate giant cells in this process. In addition, we see this same finding here adjacent in these sub-epithelial areas elsewhere. And so this is an interesting question that the surgeon asked me. Could this be just hidradenitis suppurativa, or is this cutaneous involvement by Crohn's disease? And that question, I think, is answerable. First of all, on the basis of the pattern of the inflammation. So this inflammation is really identical to what the patient had in the perianal tissues, which were ulceration, granulation tissues, some fissuring formation, and this variable giant cell and myxoid response. And the distribution of the disease. Now, in hidradenitis suppurativa, the disease is centered on these apocrine and sweat gland areas that are at the juncture of the dermis and the subcutis. And we don't really see that here. These glands are spared. There's no real deep level of involvement here other than where we're close to the actual ulcer. And these other areas over here, that we're not seeing any of that residual tissue. Now, obviously, the ulceration is extending deep here. It could have destroyed those tissues in the process. But the fact that the areas adjacent here were showing this lesion, I think, or they're showing the giant cell reaction and the superficial inflammation, I think makes a nice case that this is Crohn's disease involving the inguinal area as well as the perianal area in this patient. So with that, I'm going to skip that last case. We're over time already. And I will, at this point, thank everybody for some great comments and great questions. I'll stick around for a minute or two if anyone else wants to ask any further questions. But we will, as I said, post the recording on our discussion later today for review or for those who may have missed the first part of the cases. So any questions or comments to wrap up? Thanks, everyone. Thanks, Hui. Jennifer, glad you could join us. Good luck in your program. All right, well, we'll see you next month for flat lesions of the bladder with our guest professor, Dr. Apari Murugan.
Well, thank you. Have a good day.